Hi friends, in today's video we're going to be talking about heart failure. So if you like this video, make sure to give it a thumbs up and subscribe to the channel. We make a bunch of different nursing content to help you guys with your nursing classes and to pass NCLEX. All right, let's get into it. All right, so heart failure is what we're going to be talking about today. So what is heart failure? It's also known as congestive heart failure, and it's recognized as a clinical syndrome with signs of fluid overload or inadequate tissue perfusion. It is the inability of the heart to pump sufficient blood to meet the needs of different tissues for their oxygen and nutrient needs. The term heart failure indicates myocardial disease in which there is a problem with contraction of the heart, which is the systolic dysfunction, or filling of the heart, which is diastolic dysfunction, that may or may not cause pulmonary or systemic congestion. Heart failure is most often a progressive, lifelong condition that's managed with lifestyle changes and medications that can help to prevent episodes of acute decompensation and heart failure. All right, so classification. So heart failure is classified into two types. There is left-sided heart failure and right-sided heart failure. So left-sided heart failure or left ventricular failure have different manifestations than right. So we're going to compare the two. In left-sided heart failure, pulmonary congestion occurs when the left ventricle cannot effectively pump blood out of the ventricle into the aorta and the systemic circulation. So remember that the left ventricle, it's thicker than the right because it's stronger and it's a little bigger, and it's because it needs to pump that blood through the entire body. So it is going to be stronger. So in left-sided heart failure, that left ventricle cannot effectively pump the blood to the rest of the body, so the blood is backing up. And when the blood backs up, we are going to have pulmonary congestion. And that's because, remember in anatomy, when the blood is going through the heart, it goes from the right side of the heart to the lungs where it gets oxygenated, and then goes into the left side of the heart where it gets pumped throughout the body. If the left side of the heart is not able to pump it throughout the body, it's backing up, and all that fluid is backing up from the left ventricle into the lungs. So we're going to see a lot of pulmonary congestion. And this is going to lead to pulmonary venous blood volume and pressure increases. It's going to force fluid from the pulmonary capillaries into the pulmonary tissues and alveoli, causing pulmonary interstitial edema and impaired gas exchange. Again, if we look at this little person, we're going to see that they are exhibiting signs of pulmonary congestion. So they're going to have difficulty breathing, tachycardia, exertional dyspnea, fatigue, cyanosis. The pulmonary congestion is going to lead to the cough, crackles, wheezing, blood-tinged sputum, tachypnea, because again, all that fluid is in the lungs. All right, so let's take a look at right-sided heart failure. So when the right ventricle fails, congestion in the peripheral tissues predominates. This means that the right side of the heart cannot eject the blood and cannot accommodate all the blood that's returning from the venous system. So you have all that blood in your body and it's all coming back into the right side. So remember, it goes right side, lungs, left side. So it's backing up in the right side, therefore backing up throughout the body. And when this happens, it's because the right side of the heart cannot eject the blood, and it is increasing the venous pressure, which is leading to something called distended jugular veins and increasing capillary hypostatic pressure throughout the venous system. So that's why if we look at this woman, she is having distended jugular veins because that is the blood backing up is making a lot of pressure in those veins. There may be anorexia or complaints of an upset stomach, swelling of hands, feet, and fingers, dependent edema, ascites, so a lot of that fluid in the belly, enlarged liver or spleen, fatigued, and peripheral venous pressure increases. So again, if the right side of the heart is failing, all of that blood is backing up throughout the body. So with the right side heart failure, you're going to see that edema. You're going to see the jugular vein distension. When we talk about peripheral pulses, if you're taking someone's pulse and it's bounding and really hard, that is the backup of the fluid into the venous circulation. So classifications of heart failure. So there's these 4 different stages. Stage A is a patient at a high risk for developing left ventricular dysfunction, but without structural heart disease or symptoms of heart failure. Stage B, patients with left ventricular dysfunction or structural heart disease that have not developed symptoms of heart failure. Stage C, patients with left ventricular dysfunction or structural heart disease with current or prior symptoms of heart disease. And stage D, patients with refractory end-stage heart failure requiring specialized interventions. All right, so let's look at the pathophysiology of heart failure. So heart failure results from a variety of cardiovascular conditions, which include chronic hypertension, coronary artery disease, and valvular disease. So as heart failure develops, the body activates certain compensatory mechanisms. Systolic heart failure results in decreased blood volume being ejected from the ventricle, and the sympathetic nervous system is then stimulated to release epinephrine and norepinephrine, which decreases renal perfusion and causes renin release, and then promotes the formation of angiotensin 1, which is converted to angiotensin 2 by our ACE inhibitors, by our ACE system, which constricts the blood vessels and stimulates aldosterone release that causes sodium and fluid retention. There is a reduction in the contractility of the muscle fibers of the heart, and workload increases, and then there is compensation of the heart for the increased workload by increasing the thickness of the heart muscles. So I thought that this outline was a good summary of the pathophysiology of heart failure. So you have coronary artery disease and hypertension or valvular disease, which leads to heart failure, which leads to a decreased cardiac output and leads to the body feeling fatigued and weakness. When there is decreased cardiac output, the activation of the sympathetic nervous system occurs and the activation of the renin, angiotensin, aldosterone system, which then increases retention of sodium and water, which is going to show us that edema and weight gain, which is then going to lead to increase in venous pressure and increase in venous congestion. And then you're going to see these different signs depending on the type of heart failure that you have. So we went over this earlier, but if it's right-sided, you have the anorexia, nausea, pain in the upper right quadrant, algeria during the day, polyuria at night. When you have symptoms of left-sided heart failure, your dyspnea, orthopnea, nocturnal dyspnea, cough, wheezing, and you're also going to see some physical signs and symptoms. So maybe different types of rhythm, ascites, peripheral edema. So these are, again, the pathophysiology of the different heart failures. So statistically, more than 5 million people in the United States have heart failure. There are over 500,000 cases of heart failure diagnosed each year. It costs the United States $33 billion annually, and it is considered an epidemic in the United States. So heart failure can affect both men and women, although mortality is higher in women. And there's also a lot of racial differences. At all ages, death rates are higher in African Americans than non-Hispanic whites. And heart failure is primarily a disease of older adults, affecting 6 to 10% of those over 65. And it is also the leading cause of hospitalization in older people. So the causes of heart failure include coronary artery disease. So atherosclerosis of the coronary arteries is the primary cause of heart failure, and coronary artery disease is found in more than 60% of patients with heart failure. Also ischemia, which deprives the heart cells of oxygen and leads to acidosis from the accumulation of lactic acid. Cardiomyopathy is usually chronic and progressive. Systemic or pulmonary hypertension, so increases in the afterload, result in hypertension, which increases the workload of the heart and leads to hypertrophy of the myocardial muscle fibers. A lot of words. Valvular heart disease is when the blood has increasingly difficult moving forward and it increases the pressure within the heart and increases cardiac workload. So again, if we have that left-sided heart failure, because I can almost guarantee you guys are going to get questions left versus right on your exam. So left-sided heart failure, you're going to see that dyspnea, shortness of breath, which may happen with minimal or moderate activity. The cough that is associated with left ventricular failure, it's usually dry and non-productive. You may have some pulmonary crackles, and they can usually be auscultated across all lung fields. And you're going to get low oxygen saturation level. So then right-sided heart failure, you may see enlargement of the liver, accumulation of fluid in the peritoneal cavity, and loss of appetite. So to prevent heart failure, we want to promote healthy diet with our patients. Avoiding the intake of fatty or salty foods will greatly improve heart health. Encourage cardiovascular exercises, typically about 3 times a week is what a lot of books will say, and smoke cessation, because nicotine is a vasoconstrictor and that can increase pressure within the vessels. So complications with heart failure are typically related to diuretics or related to heart failure therapy. So our treatments for heart failure, it's usually due to diuretics. So you may see some hypokalemia. We want to make sure to be monitoring for that because of excessive and repeated diuresis. Hyperkalemia is also something we need to watch for because of use with ACE inhibitors, ARBs, or other diuretics. Again, prolonged diuretic therapy can lead to hyponatremia and result in disorientation, fatigue, apprehension, weakness, and muscle cramps. And we can also lead to dehydration and hypotension because we are depleting the volume of blood by getting rid of fluid. All right, so our assessment and diagnostic findings. So these are some tools we can use when we are assessing the patient. We can look at an ECG, which will let us know about ventricular or atrial hypertrophy, ischemia, and different damaging patterns that may be present. It can also identify dysrhythmias, tachycardia, AFib, conduction delays such as left bundle branch block. Any PVCs can be seen. We can also identify ST segment abnormalities and any decrease in QRS amplitude. We can use a chest x-ray, which can show enlargement of cardiac shadow, can reflect chamber dilation and hypertrophy or changes in blood vessels. We can see an increase in pulmonary pressure based on what the heart looks like in our chest x-ray. We can look for abnormal contours such as bulging of the left cardiac border, which can suggest ventricular aneurysm. We can use sonograms such as an echocardiography, a Doppler, and transesophageal echocardiography, which can reveal enlargement chamber dimensions, alteration in valvular function and structure, and the degrees of ventricular dilation and dysfunction. We can also look at a heart scan, which measures cardiac volume during both systole and diastole. It measures ejection fraction and estimates wall motion. We can use something called a stress test, and then these can be administered in 2 different ways. So you can do an exercise stress test. So they'll hook the patient up to a monitor, have them walk on a treadmill and monitor the heart, or they'll use a pharmacological stress test. So they'll give them a medication that will create the same increase in heart stress that someone might get from exercising. to be able to look at myocardial ischemia and wall motion abnormalities. They can also use something called positional emission tomography, or a PET scan, which is a sensitive test for evaluating the myocardial ischemia or detecting viable myocardium. Or they might use a cardiac catheterization. So abnormal pressure are indicative of help differentiating right versus left-sided heart failure, as well as valve stenosis or insufficiency. Also assesses patency of coronary arteries. They may use a contrast injected into the ventricles to reveal abnormal size and ejection fraction and alterations in contractility. And they can even do biopsies to determine any underlying disorders, such as myocarditis. We can also look at some labs. So when looking at labs, we may evaluate liver enzymes, which can show elevation in liver congestion or failure. So if those liver enzymes are elevated, that could indicate the liver congestion or failure. We can also look at levels of cardiac drugs to make sure we're in the correct range. Digoxin. We can look at bleeding and clotting times to determine if the therapeutic range is correct or if the patient is at risk for clot formation. Look at electrolytes, which can be altered due to decrease in renal function or diuretic therapy. We will use a pulse oximeter to assess for oxygen saturation of the blood, especially in acute heart failure, or if somebody has heart failure with COPD or chronic heart failure. This is just a really good, easy test that we can do. We can look at arterial blood gases. Left ventricular failure is characterized by mild respiratory alkalosis during the early stages, or hypoxemia with an increased PCO2 in late. So we can look and see those levels in the blood, carbon dioxide and alkalosis. We can look at the BUN and creatinine. So an elevated BUN suggests decreased renal perfusion, and an elevation of both BUN and creatinine is indicative of renal failure. We can look at serum albumin and transferrin, which may be decreased as a result of reduced protein intake or reduced protein synthesis in congested liver. And we can look at a complete CBC, which may reveal anemia, any dilation changes that are indicative of water retention. We can look at the white blood cells to see if they're elevated, which can reflect a recent or acute MI, pericarditis, or other inflammatory or infectious states. We can look at the ESR, which may be elevated, indicating acute inflammatory reaction. And we can even look at some thyroid levels, because increased thyroid activity suggests thyroid hyperactivity is a precursor of heart failure. Management of heart failure. The overall goal of managing heart failure is to relieve patient symptoms, improve the functional status and quality of life, and extend survival. So, pharmacological therapy. Things we may use are ACE inhibitors, which slow the progression of heart failure, improve exercise tolerance, decrease the number of hospitalizations for heart failure, and promote vasodilation and diuresis by decreasing afterload and preload. We can also might be giving these patients angiotensin II receptor blockers. They block the conversion of angiotensin I to angiotensin II, remember in our pathophysiology. And this causes a decrease in blood pressure, a decrease in systemic vascular resistance, and improved cardiac output. We may be giving some beta blockers to reduce the adverse effects from the constant stimulation of the sympathetic nervous system. We may be giving diuretics to remove that excess extracellular fluid. And we may be giving some calcium channel blockers, which cause vasodilation and reduce systemic vascular resistance, but is contraindicated in patients with systolic heart failure. All right, so nutritional therapy, we may be putting these patients on a sodium restriction. So a low sodium diet of 2 to 3 grams a day reduces fluid retention and symptoms of peripheral and pulmonary congestion and decreases the amount of circulating blood volume, which decreases myocardial work. We also want to look at patients' compliance. It's important because dietary indiscretions may result in severe exacerbation of heart failure requiring hospitalization. So we can put patients on these diets, but we also want to make sure they're being compliant with them and let them know that if they're not, that can be very troublesome. So additional therapies, we may have these patients on supplemental oxygen based on the degree of pulmonary congestion and resulting hypoxia. They may be on cardiac resynchronization therapy, which involves the use of a biventricular pacemaker to treat electrical conduction defects. These patients might be on ultrafiltration. It's an alternative intervention for patients with severe fluid overload. They may be on a cardiac transplant. So if they're in end-stage heart failure, really this is the only treatment option for them. So our nursing assessment, we're going to focus on observing the effectiveness of therapy for the patient's ability to understand and implement self-management strategies. So to do this, we first want to take a health history. We want to assess signs and symptoms such as dyspnea, shortness of breath, fatigue, edema. We want to assess for those sleep disturbances. Do they have to get up in the middle of the night because of shortness of breath? And we want to explore their understanding of heart failure, what their current self-management strategies are, and the ability and willingness to adhere to our recommendations. So a physical exam is going to incorporate auscultating the lungs for presence of crackles and wheezes. Put those together for a second. We're going to auscultate the heart for the presence of an S3 heart sound. We're going to assess for that jugular vein distension. We're also going to evaluate their level of consciousness, their mental status. Remember, mental status can indicate electrolyte changes, especially hyponatremia. Anything with sodium is usually going to affect the brain. That was, I remember, a big thing when studying for NCLEX in nursing school. We know that potassium affects the heart, but sodium typically affects the brain. So if you're getting a question with mental status changes, it is most likely a sodium issue. Evaluate or assess the dependent parts of the patient's body for perfusion and edema. We're going to assess the liver for hepatojugular reflex. We're going to measure the urinary output carefully to establish a baseline against which to assess the effectiveness of the diuretic therapy. We want to weigh the patient daily in the hospital or at home because, again, weights are going to indicate the fluid volume loss. So these are different diagnoses or nursing diagnoses we can give our patients. Activity intolerance related to decreased cardiac output, excessive fluid volume related to heart failure syndrome, anxiety related to breathlessness from inadequate oxygenation, powerlessness related to chronic illness and hospitalization, an ineffective therapeutic regimen, management related to lack of knowledge. So our planning and goals should include promoting physical activities, reducing fatigue, relieving fluid overload symptoms, decreasing anxiety, increasing the patient's ability to manage anxiety, treating the patients about self-care programs, encouraging the patient to verbalize his or her ability to make decisions and influence outcomes. Nursing interventions, so we want to promote activity tolerance, we want to manage fluid volume, we want to control anxiety, and we want to minimize powerlessness. So to do this, to promote activity tolerance, a total of 30 minutes of physical activity every day should be encouraged, and the nurse should collaborate with the interdisciplinary team to schedule and promote pacing and prioritization of activities. To manage fluid overload, the patient's fluid status should be monitored closely by auscultating the lungs, monitoring daily body weights, and assisting the patient to adhere to a low-sodium diet. Controlling anxiety. When the patient exhibits anxiety, the nurse should promote physical comfort and provide psychological support, and begin teaching ways to control anxiety and avoid anxiety-provoking situation. And to minimize powerlessness, we want to encourage the patient to verbalize their concerns and provide the patient with decision-making opportunities. Trauma-informed care, very important. Nurse priorities should be to improve myocardial contractility and systemic perfusion, reduce fluid volume overload, prevent complications, provide information about disease prognosis, therapy needs, and prevention of reoccurrences. Our evaluations, so these again are what we're evaluating based on our diagnoses and our interventions. This may not necessarily be what you have evaluated. These are just some examples. So demonstrated of tolerance for increased activity, maintained a fluid balance, less anxiety, decides soundly regarding care and treatment, and adherence to self-care regimen. So discharge and home care. So big one, always patient education. So we're going to teach the patient and their families about medication management, low sodium diets, activity and exercise recommendations, smoke cessation, and learning to recognize the signs and symptoms of worsening heart failure. And we're going to encourage the patient and their family to ask questions so information can be clarified and understanding enhances. So these are our goals for discharge. And again, these are just some examples: cardiac output adequate for individual needs, complications prevented or resolved, optimal level of activity and functioning attained, decreased, progress in prognosis and therapeutic regimen understood, plan in place to meet needs after discharge. And these are our documentation guidelines. So we want to document our assessment findings, that I&O, fluid balance, degree of fluid retention, results of laboratory tests and diagnostic studies, response to interventions and teachings and actions performed, and attainment or progress towards desired outcomes. All right, so that is the lecture or information on heart failure. If you guys enjoyed this video, make sure to give it a thumbs up and subscribe below. We have nursing content for nursing school and NCLEX to help you guys understand, and also make sure to check out the website in the links below. I do have an NCLEX study guide, and I'll be putting these PowerPoint slides up if you want to use them as a study reference. All right, bye guys, have a good day.